Very good morning and welcome to another Health AI Institute roundtable discussion focused today on the critical area of healthcare supply chain. We are thrilled to have Professor Anant Mishra with us to share his insight with a session moderated by Gopal Khanna. Gopal is the co-founder and chairman of the Health AI Institute. He has held senior executive position in the industry, launched and advised many startups, and is a distinguished public servant. Mr. Khanna was a member of Minnesota Governor Tim Paul Lenthi's cabinet and has held senior executive and foreign service policy position in federal government, where he served in the administration of President George W. Bush and President Donald J. Trump. Most recently, Mr. Khanna was the fifth director of Agency for Healthcare Research, which is named as ARC, at HHS in Washington, D.C. As a CXO advisor and a board member, Gopal works in public and private sectors at the intersection of healthcare, technology, and government. I'd like to hand over to Gopal to lead the discussion with Professor Anant Mishra.
Thank you, Ikram. Appreciate your leadership at the Institute. So let me welcome all our guests here in the States as well as all over the world. We appreciate you joining us for a discussion on the convergence of technology, policy, and practice as we enter the new era of artificial intelligence. What we are really seeing is the dawn of the fifth industrial revolution. There is definitely a growing frustration amongst patients, providers, and policymakers that we are moving further and further away from our ultimate goal of patient centeredness and from providing care that is efficient, effective, and of high value for the people we serve. Amongst others, siloed construct of healthcare industrial complex has contributed hugely to the dysfunction and highly fragmented approach to delivery of care. The grand challenge before us is how to take advantage of AI and leverage new technologies to break the perennial silos in the healthcare sector and drive innovation to achieve a more integrated, coordinated, and whole person care. What is really needed is an ecosystem view to ensure we do not miss the opportunity AI provides us to innovate and define the new frontier by design rather than stumble into the unknown. With innovation in mind, we here at the Health AI Institute are organizing roundtable discussions with leading experts with whom we can have nuanced conversation on AI and its impact on different aspects of health and life sciences complex. And add to that, what could be the transformational opportunities for the future? So in essence, we want to learn from experts about application of AI in different settings. We want to hear what they see as opportunities for AI-driven innovation, and we want to understand how to mitigate risks associated with AI and build an integrated healthcare ecosystem for the future. We're pleased today to have with us Professor Anant Mishra. Anant Mishra is the Andrew Van Dean Professor of Supply Chain and Operations at the Carlson School of Management at the University of Minnesota. His current research interests derive from contemporary issues in the areas of public health supply chain, emerging market operations, and innovation. Professor Mishra's research has been published in leading academic journals. He has worked with and advised global companies on a range of supply chain issues. Professor Mishra will share with us this morning his insights on innovation in public health supply chains, precision medicine, and emerging market operations. Now, when we talk about supply chain, people generally think in terms of products. They're manufactured in China, India, Vietnam, or wherever it might be, and how they come to the customers. Healthcare, too, is also about supply chain, and that's extremely integral and requires deep thinking. So I'm really happy that we have Professor Mishra with us to share his insights. There will be a Q&A session after the presentation. It will be led by my colleague Ikram Khan, Senior Fellow at the Institute. Please feel free to submit your questions during the course of the presentation. Ikram will be collecting them and will lead the Q&A discussion. So with that, Professor Mishra, thank you for joining us. The virtual floor is all yours. Thank you, Anant.
Thank you, Gopal, and thank you, Ikram, for giving me this opportunity to present my work and giving this opportunity to also interact with your audience. I think this is a terrific forum, the Health AI Institute, and it's also an opportunity for us, within also the University of Minnesota to connect and share our work and also get to know how the different institutions within the University of Minnesota are thinking about healthcare in general, to share and exchange our point of views, but also to understand more broadly the challenges within healthcare, and hear from the audience and see how we can tackle some of the uh, bigger issues within the healthcare, and see what are some of the potential solutions within it, how much inroads we can make. Now, what I'm going to talk about today is I'm going to talk about two ongoing projects that we're currently working. My name is Anant Mishra. I'm a faculty at the Carlson School of Management. I'm a professor in the supply chain and operations management area, which traditionally, when one would think of, is very distinct from healthcare management area. But in the business school, I can assure you that there is a lot of people who are focused on healthcare management, because healthcare is something which is cross-cutting in terms of its focus, and there is a ton of people in the area of business that are focusing on understanding how we can deliver healthcare better, how we can manage healthcare better, and how we can make sure that the last mile delivery in terms of healthcare is actually done properly, not just in the context of developing economies, but also in the context of developed economies like US in particular. So I'm going to focus on two projects here. And the basic idea is advancing healthcare through innovative supply chain solutions. So the focus is not explicitly on AI in particular, but the focus is more on innovative supply chain solutions here in the context of it. So 15 minutes on each project is what I'm looking at as I'm focusing on this, right? So let me first very quickly define what I mean by healthcare supply chains, and then I'll briskly go through some of these two projects and look forward to hearing your thoughts on this. So when we think about supply chain, and as Gopal very rightly mentioned, when you think about supply chain, we're thinking about physical products and typically products that you can feel and touch and feel and stuff like that. But healthcare, the whole process, healthcare is effectively a supply chain. And so when we say healthcare supply chain, what are we actually talking about? Healthcare supply chain is effectively an extensive network of systems, components, and processes that collectively work to ensure that medicines and other healthcare supplies are manufactured, distributed, and provided to patients. So if you think about the end point in the healthcare supply chain is a patient, people like us, people like you, who are the receivers, the customers. But then you have individual layers, which are typically the wholesaler, you have the hospitals and the clinics which deliver the care, the wholesalers, the manufacturers, and then you have the secondary manufacturers, the suppliers, and then the producers of the raw material out here. So each one of those layers effectively has to function, and that is what we refer to as a supply chain. And in general, like any supply chain, whether we are talking about an electronic supply chain or a physical product supply chain, ensuring equitable access of healthcare supplies to patient is the foremost objective of healthcare supply chains. And that needs to be done, again, also in a fairly profitable manner also for the supply chains to be sustainable. So that is something which is quite a bit of focus of faculty doing research across business schools globally, not just in US, but globally out here. So with that in mind, I'm going to talk about two projects. The first one is based on a developing economy context, which looks at frontline health workers and how they tackled stockouts of contraceptive products in the setting of Indonesia. It's a fairly straightforward project in terms of contraceptive product stockouts. I'll talk a little bit about our findings in that. And the second one, fairly removed from developing economy, we are going to talk about precision medicines, which is again quite a bit of focus of the healthcare AI Institute out here. So let me dive into the first project out here, which is tackling contraceptive stockouts in the context of Indonesia, and why we are focusing on this particular project out here. Right. So this is a work with a bunch of colleagues, Amir Karimi at University of Texas at San Antonio, myself, Anant Mishra, Karthik Natarajan, and KK Sinha at the University of Minnesota, Carlson School of Management. And then we have two industry collaborators out here from John Snow Inc. They have helped us tremendously in providing the data and also providing feedback in terms of the work and providing the external validity. So it has been a very valuable collaboration for us as we have developed this project, right? So what is the motivation for this project? So if you think about healthcare supply chains and why it matters particularly, and if you look out at the UN Sustainable Development Goals, the United Nations has an entire set of sustainable development goals for the next several decades. And one of the main goals in terms of sustainable development is goal 3, which says ensuring healthy lives and promoting well-being for all at all ages. And within that, if you start unpacking, goal 3.8 says ensuring universal access to safe, effective, quality, and affordable essential medicines and vaccines for all. Goal 3.7 says universal access to sexual and reproductive healthcare services, including family planning products, right? So 3.8 is understandable, essential medicines and vaccines for all. But what is it about 3.7? Like, why does sexual and reproductive healthcare services, family planning products actually matter so much? Why does the UN, for example, care so much? Why does it figure out in terms of the Sustainable Development Goals? And this is something that we started diving into in more detail. And so let's look into this a little bit more specifically. So think about this particular picture. And this is not uncommon in the context of low-income countries in particular. Right? So every day, thousands of women in developing countries embark on a futile journey. Now, what is it about this picture and why is this journey futile, right? So typically you would have women which are very poor, working in day jobs, hourly jobs typically, and the journey is futile because these would be women who would be making a journey from working in far off villages, making a journey to particularly a small town or a district to procure medicines, and typically those medicines might be oftentimes contraceptives. These women may not necessarily be as interested in using contraceptives, or may not have an idea about using contraceptives, and they might have received information about using contraceptives, and after much coaxing or prodding, they might have decided, okay, let us give it a try. And the journey is, however, futile because when they spend an entire day after much effort taking time out of her job and going to a nearby town or a district to go to the place, here's what they find out. They find out that the place where they're seeking that contraceptive, the contraceptive is out of stock. And this is very typical, particularly in low-income countries or developing economies. More often than not, you have NGOs and non-profit organizations do a fairly stellar job in passing the information about the value of contraceptives and why it is important. But the actual product availability is fairly low. And this is not specific to one particular country, low-income country or developing economy country. This is actually fairly common across large swath of countries. For example, especially in Africa as well as Southeast Asian countries, Senegal, for example, in mid-2015s, for example, 70% of health facilities had at least one contraceptive method out of stock in 2012. In Nigeria, 50% of health facilities had at least one contraceptive method out of stock. 1 out of every 10 days out of stock. Kenya, 60% of health facilities, one contraceptive method out of stock. This happens in Pakistan. Indonesia is very common. I know coming from India, this is something which is not uncommon at all and very rampant in rural towns as well as in villages out there, where there is less interest in having contraceptives and when there is interest and people go, stockouts is something which is very, very common out there. So then the question is, the whole purpose of, creating awareness is defeated when you have these challenges of stockout out there. So the question is, well, why do we actually have these challenges of stockout out there, right? And what is the challenge of stockout? So let me first explain a little bit about why these challenges of stockout occur, and then why do we focus on the context of Indonesia in particular. So one of the challenges why stockouts tend to happen, and based on our conversation with practitioners and collaborators from John Snow, was that oftentimes in health facilities where these products are available, the reasons why stockouts happen are that the people who are keeping track of inventory of contraceptives, the people who are keeping track of them, those people are not necessarily trained in inventory management. Their primary responsibility is managing contraceptives in terms of providing health advice or feedback on health. So they are health workers. They are not necessarily workers who are trained in inventory management. In other words, inventory management or keeping track of contraceptives or keeping a logbook of contraceptives, that is secondary to them. And so what happens is that they don't keep track of this. And so oftentimes they're not necessarily aware of as to how much stock of any particular product or any particular medicine is out there. So this is a very typical problem, and it's a secondary responsibility because of which they're not aware. And this lack of awareness of keeping track of inventory of stockout becomes a serious challenge when you constantly experience these stockout issues out there, right? Now, why focus on Indonesia in particular in this context of our study? Why not focus on, for example, other countries in general? So if we look at the context of Indonesia, here are some interesting facts about Indonesia. Indonesia is the fourth most populous country in the world. Largest population of women in 15 to 49 years range, which is typically the range within which contraceptive requirements is fairly large, childbearing age in general. The government has focused quite a bit in Indonesia to manage population growth for long-term economic and social well-being. I mean, this has been on the agenda of the Indonesian government for a long time. And since 2002, the contraceptive prevalence rate in Indonesia has been fairly stagnant at 60%. So they worked on it quite a bit, and it went as high as 60% till 2002. And from 2002 onwards till even 2017, it has barely risen from 60% to another additional 1.5%. And so despite the government efforts out there, right? And so this has created quite a bit of challenges that despite all the efforts in creating awareness, the fact is that the prevalence rate of contraceptive has not necessarily risen. And Indonesia continues to be the fourth most populous country in the world. So taking all that into consideration, the Indonesian government decided to work with John Snow Inc. and along with Bill and Melinda Gates Foundation, and reached out to these organizations to see how can we improve the contraceptive prevalence rate. What can we do out here? Now, John Snow Inc. decided to look at this possible idea of, can we do better training of these workers, these health workers, whose primary responsibility is to deliver health advice, to provide these health commodities, to provide contraceptives, but can we do better training on the inventory management? And how much does training actually help in reducing stockouts? And what are the effects of providing training? Does training help? And so this is how we got in contact with John Snow Inc. We started reaching out to them to see, for example, to evaluate, for example, as they were implementing this program, that can we actually rigorously study empirically the impact of training on stockouts and evaluate in a much more rigorous fashion as they were conducting the study, the true impact of training on stockouts as well as the public health implications. So we were working alongside with Omar Balsara and Barbara Lampier as they were implementing some of these training programs on the ground to see what are the implications out here. So very quickly, the two questions that we are studying in this context were straightforward. One is in terms of training, assuming that we are training health workers in inventory management, the questions were very tactical. Where should inventory management training be delivered, right? Should it be delivered on-site or should it be delivered off-site? Because there were logistical challenges in terms of delivering training, right? How much does effectiveness of training differ if you provide on-site versus off-site? And who should deliver the training? Does it matter, for example, if you send the same trainer? Or does it matter, for example, if you send different trainers, right? If you're doing repeat training, especially of the health workers, does it matter if you send a different trainer each time? Is there kind of a benefit to sending a different trainer? Or is there a benefit of sending, for example, the same trainer time and again? What is the impact of repeat training from unfamiliar trainers versus the same trainers out here? And these were questions that we were looking at because there were major resource constraints, especially in these settings. So what are our findings with regards to some of these questions? What was the data that we were collecting here, right? So the data that we were looking at that came from here was significant. So data that we collected as a part of this research was between 2015 to 2019, close to 2 million observations collected from the health facilities. And we were evaluating the impact of training of health workers to evaluate how much does training matter. Does on-site training matter versus off-site training matter? What is the impact, right, in terms of stockouts as well as health impact? And does it matter whether you send familiar versus unfamiliar? So we looked at across provinces, across multiple districts, across 18,000 facilities. And this is a very rigorous causal analysis that we refer to as difference and difference analysis in our academic settings research out here. So here is what you find in terms of the impact out here. So we had these two hypotheses, off-site versus on-site, and I'm presenting the graphical results here. So interestingly, what we find is that when we're looking at off-site training, where we are inviting, for example, a whole host of people to one particular location, which essentially ensures that you are training hundreds of people at one particular location. It is much more easier logistically, and there's a lot more exchange of information even among the health workers, especially in one location. Very convenient for example, such training workshops to be done. The question is, how much does it impact the outcomes? What we find is that offsite training, even though it was convenient to execute, the impact in terms of reducing stockouts was very marginal to none, both in the short term as well as in the long term. So if you can see in terms of these outcomes, you can see that the effect is close to zero in terms of impacting the outcomes in terms of stockout. But when you look at on-site training, while on-site training requires more resource allocation in terms of individuals going to the site to train workers and basically trying to execute on the site, informing workers, talking to the workers, you can see clearly there is a major advantage in terms of the benefits of the training actually sticking and showing advantage. So the difference is fairly palpable in terms of on-site versus off-site training, especially when it comes to these kind of settings out there and training healthcare workers. So we find that on-site training is clearly effective in such settings compared to off-site trainings out here. And this is something that we have passed on to John Snowing as well as, for example, to the government of Indonesia in terms of implementing some of this impact out here. Now, the second thing is that what about trainers, right? Sometimes you have trainers available, sometimes you have the same trainers not available. So the challenge in the minds of people who were allocating trainers were like, if you don't have the same trainer available for repeat visits, would it actually hurt the whole training regimen? What difference would it make? And here is an interesting finding that we were not necessarily directly expecting. There are benefits of familiar training, when you send the same trainer time and again, see this, the familiarity with the trainer means that you develop a sense of comfort level with the same trainer. That means you also have a better ability to learn. You have a better ability to learn and you have a better exchange. But what we actually find is that when you send unfamiliar trainers for repeat visits, the reduction in stockouts is actually much more higher, right? So what it is pointing out is that when you send different trainers each time, as long as they're following the same protocol, when you send different trainers each time, what is happening is that the health workers are not necessarily always in the comfort zone when they're getting different interventions. The trainers are all following the same protocol, but each time when you send a different trainer, the health workers typically are out of their comfort zone, and each trainer might be bringing slightly different perspective and pushing, for example, the health workers in different directions. And so the learning is much more steeper in those cases. You can see, for example, that unfamiliar follow-up on-site training provides a much more bigger bang for the buck when it comes to reducing stockouts in this setting out here and contraceptive stockouts in these kind of settings. Right? And so finally, if you look at, okay, this is reduction in stockouts and so, but what about the public health benefits, right? In terms of on-site training, we see 24% additional reduction in stockout compared to off-site training. In terms of unfamiliar follow-up on-site training, we see 8% additional reduction in stockout that we see here. But what about, for example, the public health implications? How much does this additional reduction in stockout because of on-site training and unfamiliar follow-up training impact public health? So if we extrapolate these results and using, for example, a stockout calculator that is fairly common in these kind of settings, what we can extrapolate is that the benefits are actually quite significant. So in terms of off-site training versus on-site training, an on-site training compared to an off-site training has significant impact in terms of averted unintended pregnancies as well as averted maternal and newborn deaths. For example, on-site training in general in this setting compared to off-site training, on-site training can avert roughly 8,400 unintended pregnancies in our setting compared to, for example, off-site training, which roughly averts 2,300 unintended pregnancies. Now, if you look at averted maternal and newborn deaths in this setting, we can see, for example, on-site training has the potential to avert approximately 45 maternal and newborn deaths based on our calculations compared to roughly 12 averted maternal and newborn deaths based on off-site training. So the differences in on-site and off-site training are quite material when you look at the comparisons in terms of the effect sizes. Similarly, unfamiliar and familiar training, the differences in terms of public health impact is quite significant out here. So what we are saying is that, look, training makes a big difference. It makes a sizable difference. You don't have to go through major complicated solutions to make a significant public health impact. Simple solutions like training in inventory management, training in supply chain management can make a big difference in terms of achieving impact in some of these UN Sustainable Development Goals. So that is a first paper that I wanted to share some insights here. Are there any immediate questions I should handle right now, Gopal or Ikram, or should I go ahead to the next one?
Yeah, please go on. We are compiling those questions. We'll
sure.
Come up at the end of it.
Wonderful. So this is the first project that we're talking about in terms of developing economy and last mile delivery supply chain. The second one is, the first one is again an ongoing project. The second one, very different flavor, looking at precision medicine. And this is something that, again, I recently presented very recently at a conference, and I wanted to share this right away. So this is about development of precision medicine. And this whole idea is it an economic impediment or a new model of drug innovation? So very recent work that I'm sharing with all of you. And this is joint work with faculty Jingwen Yang, who graduated from here, and myself, Anant Mishra. So what is the whole genesis of this work, and what is the idea behind the study out here? So what we're trying to look into this study is the notion of precision medicine, is very promising, and we know that it has potential to make even more impact as companies are diving into it. I'll define very quickly the notion of precision medicine for many of you who may not be necessarily familiar, but let me provide the context behind it fairly quickly. So if we look at the pharmaceutical industry, the US pharmaceutical industry is facing twin dilemmas, over the last 30, 40 years. So the pharmaceutical industry for the last 30, 40 years has been um, using an approach called the blockbuster approach. Now, what the blockbuster approach does is it develops drugs for a large swath of the population. And the general idea is that most population, we develop drug for the large swath of population, and the expectation is that the drug would work generally for most of the population, assuming that there is fair amount of equivalence across people. In other words, if you're developing an asthma drug, that should generally work for most people. If you're developing a diabetes drug, it should work for the most people, as well as if you're developing a cancer drug, it should generally work for most people. But the challenge is that while asthma and diabetes might work in general for many, it doesn't necessarily hold for drugs like cancer. Cancer drugs have been very ineffective. In fact, 8 out of 10 cancer drugs are ineffective. The traditional cancer drugs have been ineffective. Similarly, if you look at, for example, osteoporosis, for example, or Alzheimer drugs, nearly 7 out of 10 Alzheimer drugs, existing Alzheimer's drugs, have been ineffective. So in other words, the blockbuster approach, which assumes that patients are equivalent and doesn't take into account genetic differences across patients, has not been working over the last 2 decades in particular. And this has been a major issue for the pharmaceutical industry. At the same time, what is also happening is that there is also a productivity crisis in the pharmaceutical industry. Pharmaceutical industry, the amount of uh, R&D investment that is being taking to develop some of these drugs is significant, and the return on investment for developing these blockbuster drugs is not coming through. So a recent Forbes article was saying that roughly $6.6 billion is being spent per drug approval, and almost half of big pharma companies are hitting negative R&D productivity. So in other words, the amount of investment is not necessarily showing returns, simply because a lot of these drugs are either are not being effective across patients, and they're not necessarily hitting the market potential out here. And so this is where companies are evaluating whether the blockbuster approach to developing drugs, is that even a right approach, or should we evaluate a different way of developing drugs? And so what is the different way? And this is where this idea of niche busters, of focusing on, rather than looking at patients as an entire, every patient is equal, and looking at patients as an entire homogeneous group, focusing on niche group of patients or precision medicine is something that is getting a lot more traction. Right? So what is precision medicine, this idea? So precision medicine, as many of you in the audience might be familiar, are tailored drug products that match with patients' identifiable biological features, um, genetic features or protein biomarkers to address their health needs. And this basic idea of precision medicine is that we recognize that each patient is different. And while there are some commonalities, that patients are different in terms of the genetic or protein biomarkers. And so the idea is to tailor therapeutics in order to match patient characteristics. Right? And so the CEO of Eli Lilly and Company, for example, says the power in tailored therapeutics is for us to say more clearly to payers, providers, and patients that this drug is not for everyone, but this drug is specifically for you, and that is exceedingly powerful. Now, all this sounds great. In some areas, precision medicine has worked brilliantly. But the question for many pharmaceutical companies still is the niche buster model economically viable? In other words, is this something that companies can see as economically viable in the long term, right? And what are pharmaceutical companies actually thinking about this? So this is not a question that we are asking, we are just asking ourselves. I mean, this is a question that is directly derived from what pharma companies effectively are asking themselves, as well as what leading researchers in the pharma space are asking themselves, right? So for example, uh, if you look at articles that came up, in fact, in the last 4 or 5 years, people have asked and researchers have asked, there is a potential profitability challenge that pharma companies are evaluating. When we think about this notion of precision medicine, here is what is happening. When you identify a biomarker that is associated with the precision medicine and that identifies a subgroup of patients, it also means that you are discontinuing some drugs from the market. So identifying a set of patients that match, a particular drug or medicine means that you are discontinuing some existing drugs for the market. So in other words, the drug market could contract. So the traditional drug market could contract, and that could be a problem for pharmaceutical companies. So that is one. And the second is that how do you actually manufacture precision medicines? The traditional medicines are manufactured on a large scale. When you're thinking about precision medicines, they would be manufactured on small lot sizes. That is not economical for many pharmaceutical companies. You don't have the economies of scale in terms of manufacturing out here. So there is a profitability challenge in that. What about the business model? For many pharmaceutical companies which are built on the blockbuster model, developing precision medicine requires an entire different set of skills. You need to have scientists, you need to have engineers, you need to have personnel who have the skill sets in terms of genomic, who need to have an entirely different set of technical skills, which may not be necessarily there with the existing set of personnel who are into, for example, blockbuster drug development. So these are some of the challenges that existing pharma companies are struggling with. And so that raises a question of, is segmenting an existing market into smaller markets, can it be an economic impediment? It might be good for patients, but could it be bad for business? So is it something which is economically sustainable? Does better medicine means worse for business? And that is something that we're trying to test out there in this particular project out here. So the questions that we address are, what is the market response to precision medicine innovation? We are trying to ask this question in a very open-ended manner, trying to see what is the data telling us out there without taking any sides on this, and how can the business side challenge be overcome? For example, are there some aspects of precision medicine development which can be improved? If there is a lot of resistance in the market, for example, if there is some uncertainty in the market in terms of market response, what are some of the factors which can actually help overcome the business side challenge? So with regards to that, one factor that we're evaluating is the role of companion diagnostics. And very quickly, I'll look at what is companion diagnostics. And companion diagnostics are effectively diagnostic devices which tell patients whether they have a particular characteristic suitable for precision medicine. So a companion diagnostic essentially provides information on whether the patient has a particular biomarker that makes them suitable. If a biomarker result is negative, it tells the patient that this particular medicine is not for them. If it is positive, it tells patient that particular medicine is suitable for them. So in other words, companion diagnostic are devices that reduce the uncertainty. But the challenge is that the pharmaceutical companies are not the ones which are actually developing some of these companion diagnostics. So what we want to know is that, is the development of companion diagnostics something which reduces the market uncertainty? Does it actually help create a better market for precision medicine out there? So these are the two questions that we're studying. And what I'll do is over the next 5 to 6 minutes, very quickly look at the data that we have here and show the results. We collect our data from the oncology sample out here. We are focused mostly on cancer drugs out there. And the reason we focus on cancer data is because predominantly much of the precision medicine development has been on the cancer side out here. So this is where the vast majority of precision medicine drugs are actually being developed out here. So this gives us an opportunity to look at precision medicine development and actually test out the sample out here. So we look at 76 drugs. It's a very painstaking data collection process that we have from 2009 to 2021 in terms of the information. And again, we use rigorous econometric analysis to do this out here. So I will not go into the analysis details out here, but we have a clear treatment and a control group. And what we are trying to do quickly is we are looking at 76 drugs, cancer drugs, where some of the drugs had an indication, which were basically a traditional indication, and some of the drugs had an indication, what we refer to as a precision indication. In other words, the drug became a precision medicine when they had an indication which told them that they were focusing on one particular biomarker that made them a precision medicine. So what we are looking at is that when a drug became a precision medicine, when the change occurred, how did that affect the market out here? So in terms of the outcome, so this is for example, how it looks like. So if you look at Afinitor, for example, this was a drug that was launched in 2009 for kidney cancer. And then the drug has other uses. For example, the drug was also used for brain cancer, pancreatic cancer, then another use for kidney cancer. So until 2012, it is effectively a traditional drug. And then in 2012, it has a precision indication, which essentially tells us that now it has turned to a precision medical indication. In other words, now it is referred to as a precision indication in the market. In other words, this drug has a precision indication. So what we're looking at is that when the drug gets an indication called precision indication, how does the market react to this change in the characteristic of the drug out here? We compare it to other drugs which do not necessarily see any changes in that out here. So when we do this analysis, just to give you background, we control for a bunch of characteristics of all these drugs out there. For example, the time, the nature of the cancer that we are taking into account, whole host of rigorous analysis to ensure that we are comparing apples to apples. And so what is the punchline in terms of the results? We find that a shift of an indication from a traditional to a precision indication creates a massive increase in drug sales. It leads to roughly 96% increase in the drug sales over a short time, but the market reacts very favorably when the indication changes from a traditional indication to a precision indication. So it's a major jump in terms of the sales out here. What happens to revenue increase? As long as you are making an incremental change, the market is reacting. But the moment you shift from a traditional indication to a traditional indication, the market shows a big jump in terms of revenue. Again, a 90% increase in drug revenue. And so you can see that the market is keeping a strong eye on how pharmaceutical companies are innovating and reacting very favorably to precision indication out here. So the market is very receptive to precision indication, even though you are segmenting the market out here. So it kind of dispels the myth that segmenting the market does not pay. Better medicine could mean better outcomes out there, right? So I'll wrap up this presentation by looking at what we see. Shifting from traditional indication to precision indication has a significant impact on drug market. Sales units increased by 96%. Drug revenues increased by 90%. We find that companion diagnostics can stimulate the market response. And so broadly, what we're doing in terms of shifting the narrative is that we're trying to address a key question at the intersection of healthcare supply chain and health economics. This is something that has been bothering quite a few people in the academic space. And we're trying to push the narrative that Better medicine, especially in this case, doesn't mean bad for business, even though we are segmenting the market. And so we are showing that this presents a compelling economic case for collaboration between pharma and diagnostic firms in terms of developing companion diagnostics out here. So these are two projects that we are working, the Indonesia project as well as the precision medicine, both work in process. And I know it's a lot to digest, but would be keen to hear your thoughts on this. Thank you.
Thank you, Anand. That was a terrific presentation, very insightful, very different, because it has brought new nuances to our attention. One thing that you talk about is using the Indonesia example and case study and talk about the supply chain, a concept that most of the people associate with products, but how it applies to even delivery of services, particularly healthcare services. I like your thoughts about precision medicine. Looks like a lot needs to be still uncovered and discovered. And as more and more data is collected, there will be, I'm sure, new approaches for innovation. The question and challenge before us is going to be, as a large community in health and human services space and life sciences space, is how to use these new technologies for innovation, because there are two sides of the same coin. One is technology in general, and AI in particular will be a disruptor. But
Sure.
on the other side of the coin is the two sides of the coin. Second one is transformation opportunities and how we will use AI to further that delivery of improvements in care, as you call it, the last mile. I have a lot of questions, but looking at the clock over here, we want to be sure that we keep the time and we respect your time. So let me give it back to Ikram. I know you've been collecting some questions, and you may have some. Please, Ikram.
Thanks,
Ikram.
Anant. I think it was a very important discussion. You touched both sides of the word. One side is on, which is still struggling with the supply chain of the basic contraceptive. Other side is thinking about precision medicine. And I'm blessed that I've been on both sides. I've been on other side for my past life, and now Jay's working on precision medicine and that scope. So lot to discuss, lot many questions, but I will go back to the first part, which is Indonesian part, and that how you have been working on publication and presenting different conferences, but some of these countries in developing economy, they are not much have resources to or knowledge experts, those who are able to train them. How you see that's a role as a academician and thinking that whatever Indonesian government have done it, and with your research, how that can be shared and adopted in vast part of the world in that region with similar healthcare issues, not only in contraceptive, but many other domain supply chain issues in the pharma and the consumables, surgical consumables, and other things.
Sure. I think it's a great question. I think for many of us, I mean, for researchers, it's a real learning opportunity to work with organizations like John Snow. I think one, we learn what they are doing on the ground uh, and what are the challenges for us doing. We are good at doing rigorous academic research, doing causal analysis, bringing the best tools. And but if we can do that and translate the results to them and learn how to present in front of and ask the right questions and present in front of them um, and help translate those, I think we also get better at sharing our results. Now, these results can be extrapolated to other settings. Here we are talking about contraceptives. I don't see any reason why you could replace contraceptives, maybe use at other products, other maybe perishable, medical products or supplies in similar settings. And the idea of training or providing simpler solutions would still apply. So I think this approach could be translated to other settings. I don't see any reason. But for us, this is a learning opportunity for us how to collaborate with other organizations, how to go on the ground and present. And I'm seeing more and more of them in business settings, academic research settings.
Oh, great. Great to hear that. And now I like to move so many questions, but like to move on the precision medicine side. And you mentioned about how the value and how much the wastage of the resources happens when the new medicine get developed. But at the same time, while we are wasting these resources, the way I see that with the precision medicine, that some of these unsuccessful molecules, which have not been gone through the whole trial to get approved by FDA, some of these molecules have potential to get through very specific niche genomic biomarker and categorizing that into populations to get approved for very specific population group. And that's how I see there's a potential that precision medicine can help reduce the wastage in terms of resources as well as in timeline to have more medicines coming into market and very niche to that population on terms of genomic data. So, but there's still a lot of confusion and chaos. That's how they will manage resources because they have to have very specific molecules for that. How you see that healthcare organization like pharma companies as well as hospital communicate this value of precision medicine to the public and the investor?
So again, that's just a very very thoughtful question, Ikram. And see, for pharma companies, one thing that we have not been able to decipher truly is that in our results, we are looking at cancer, we are finding a big impact. We have a hunch that the reason why we are seeing a big impact is that, pharma companies are also very aware of some segments of the population where, there is cancer is a fairly big area, and they know that there are some segments of the population which are likely to benefit significantly, and there's a huge market. We don't know what drugs they are finding effective and they're not putting into the market because there's just too much investment still going to happen. It's not sustainable in terms of manufacturing. It's not worth in terms of the distribution. So we don't know the drugs that they're not probably investing that much because it might be effective, but it's not worth distributing, or is not worth in terms of investing. So I think for pharma companies, are they making deliberate decisions to invest in certain drugs for precision medicine because they know there is a big market out there? I mean, that is a question that is still out there. But is precision medicine absolutely a worthwhile pursuit in terms of better match, better tailored therapeutics? I mean, it seems like it is absolutely no-brainer for certain disease categories. And what was the other? You said pharma, and you said what was the other one? The other stakeholder that you mentioned was
the hospital system.
The hospital system is something which that's a hard one. That is something that we haven't really thought about very explicitly as to how the hospital systems could do in terms of the drug delivery out there. So that is something that I would need to pay more attention to. Yeah, this stage.
Great. I think we are short of time, and I like to hand over Gopal to conclude it.
Thank you. Thank you, Ikram. I know that you've piled up a lot of questions and we'll probably put them up and respond back a little later. But Anant, thank you again for joining us. I appreciate your conversation has been very insightful. You've given us new things to think about. And of course, the challenge for us is going to be how do we tie all of your work and say, what will be the impact of artificial intelligence? How can it be used? Will it be able to answer the kind of questions that still remain unanswered? So thank you so very much. We'll be coming back to you again, Anand.
Sure.
And let me say thank you to all of you here who have joined us this morning in the country as well as overseas. Your questions that you submitted have enriched the discussion. I hope you have enjoyed the conversation with Professor Mishra just as much as I have. We will post Professor Mishra's slide deck and summary of the roundtable soon. And by the way, you shall also be hearing soon from us about our next roundtable discussion scheduled for Thursday, November 7th. Please mark your calendar. The focus will be something very interesting and different: ethics in AI and quantum computing, and looking at the world through the lens of the three T's: truth, trust, and technology. Hope you'll join us. Have a wonderful rest of the day, and thank you all.
Thank you, Gopal. Thank you, Ikram.
Thank you so much, Anant and Gopal. Yeah.